Hi everyone, my name is Liz Sampson and I'm going to be talking today about delirium and pain, and I'm really fascinated about the links between pain and delirium, and I just want to give just an idea of what an interesting and complex and fascinating topic this is. So I'll just share my screen so you can see my slides. So I'm a professor of psychiatry at University College London, and I also work as a consultant in liaison psychiatry at North Middlesex Hospital in North London, and so I see lots of people with delirium in my day-to-day clinical practice. So really an overview of why this matters, and I will talk about potential mechanisms of the associations between pain and delirium, and also how we're moving forward with some of our research. And it's just really exciting to bring this topic of pain and delirium to the forefront for World Delirium Awareness Day. So just really going back to basics, what do we mean by pain? Well, pain has been defined as an unpleasant sensory or emotional experience. So we tread on the drawing pin and that causes us to have an unpleasant experience. And often the proper definition of nociceptive pain is that it's then associated with potential tissue damage. However, there's a broader definition, which is that the gold standard of pain is self-report, and if the person regards their experience of pain, then it should be accepted as pain. Is there an association with pain and delirium? So I promise that this slide is the most kind of busy researchy slide that I'm going to show, but it's just kind of an abstract from a narrative review I wrote with Emily West and Thomas Fisher for the European Geriatric Medical Journal last year. And we just pulled together some papers, and we found lots of papers and studies that showed strong associations, not causal necessarily, but strong associations between pain and delirium. So for example, in the study by Vario et al. That was done in 2006, people in moderate pain had double the odds of developing delirium, whilst those with more severe pain had nearly 4 times the odds of developing delirium. So that's really interesting because that implies there was a dose-response relationship. The more pain that people were in, the higher chance they had of developing delirium. Other post-operative studies have shown similar findings. We found a strong association between pain and delirium in older people admitted to the acute general hospital, whereby your risk of delirium was nearly tripled by having pain. And it's also been shown to be linked in care home residents as well. So do take a look at our paper if you're interested in this topic more. The association between analgesics and delirium is really controversial and is also clinically very, very complex. And I've just summarised some of the key concepts here. There are some studies that show that being treated with opioid medications may decrease the risk of delirium because they're treating pain adequately. There's also some evidence that multimodal interventions, such as the well-known Hospital Elder Life Programme, the HELP programme, may decrease the risk of delirium, and those effective interventions always check for pain. So perhaps there's a mechanism there whereby adequate pain treatment and management might also be reducing delirium risk. There is, however, a lot of evidence that shows that high doses of opioid medications may increase delirium risk, and some really fascinating evidence about opioids that are given parenterally, so not orally, so via either intramuscular or intravenous routes. And studies have shown that when people are given lower doses of parenteral opioids, they actually seem to have a higher risk of delirium. And that sounds really counterintuitive, but actually, if you're being given opioids via that route, it's likely that you're in very severe pain. So actually, if you're given lower doses of opioid than you need to manage your pain, then this might account for this association. That's just speculation, and this is one of the great unknowns that we still have in this field. There's really, really important data and fascinating data around the role of depression in perhaps moderating or mediating the association between pain and delirium. So this is a really elegant study by Kozar et al. Done in 2014. And in this study, it was shown that preoperative pain and depressive symptoms increase delirium risk. So that's being in pain and also being depressed before your surgery increased your risk of delirium after surgery. And there is some evidence that depression in itself can lower our pain threshold, and also that depression may be a risk factor for delirium. The interaction was really fascinating, and what was found was that pain increases delirium risk more in people with depression. So at the same level of pain, people with worse pain scores are more likely to get delirium if they're depressed. Fortunately, this is a recording, so you can rewind that bit if it doesn't quite settle on the first listening. But it's worth taking some time and having a look at this slide. It's really fascinating. There's also really, really interesting theory around the role of agitation, and agitation is the clinical symptom that we deal with all the time. We know that people with delirium can become very agitated, and also that pain can cause people to become agitated. But this model from Reed and Finfer from 2014, which was developed really for ICU populations, also suggests that pain can cause agitation, hyperarousal, and this may then also increase delirium risk too. I like this model. It's really comprehensive. It brings in so many different environmental, social factors into what might be mediating the association between pain and delirium. But I think we can all think intuitively, really, how when we feel very agitated, it stimulates our sympathetic nervous system, may cause the central cerebral stress response, and that may then lower our threshold for delirium. Again, all purely hypothetical thinking, but very fascinating. Even more fascinating and still quite tentative is a putative role or a possible role of the cholinergic system. So the theory that the final common pathway of delirium is a profound decrease in central cholinergic activity is very well established now, but also cholinergic transmission greatly modifies our perception of pain. And if we activate cholinergic activity centrally, there's some evidence in animal models of pain inhibition. And this is really interesting. You know, could it be that cholinesterase inhibitors may actually decrease pain in people who are taking them? We just don't know that yet. And there's also some evidence that if we inhibit muscarinic cholinergic receptors, we can actually cause pain hypersensitivity. So here, you know, this really kind of hints, I think, at the fact that we know that the cholinergic system has a really important part to play in delirium, but also it may actually modulate pain transmission as well. And it could be a potential link between the two factors. This is another unifying theory that we kind of just developed really to underpin some of our research and to start to think about possible mechanisms. And this is in our narrative review paper from 2020. We were really interested in how pain can cause sleep deprivation, but how sleep deprivation can also lower our pain threshold. Similarly for depression, both of those factors are also known to drive delirium. Analgesics as well can drive delirium too. Pain can also drive depression. So you can see how these factors all fit together, and it's very complex but very fascinating how they may all interact in practice. So how do we detect pain in people who are delirious? Well, that can be really difficult because someone who's delirious may not be able to communicate to us that they're in pain, and they may also have dementia or other communication difficulties. They could be intubated. And this is an area of research that we've become more and more interested in over the last few years. So there is a human physiological facial expression response to pain. So all of us pull a similar face when we're in pain, and that's a fairly stable face that's actually stable across different cultures of the world. We contract our eyebrows, we contract the muscles that surround our eyes, we raise the upper lip, and often the mouth becomes open. Now, there are lots of pen and paper observational pain tools which make us look at the patient in front of us or the person in front of us And we are then directed by the tools to look at their facial expression of pain, and they can be very useful. They're not used as much as they could be in clinical practice, but studies show that observational pen and paper pain tools that look at facial expression tend to be more sensitive and more reliable. And actually, facial expression can be a better indicator of pain than physiological parameters such as pupil dilatation or changes in other blood pressure, pulse, etc. So it seems that this might be a really useful way of looking at pain in people who are delirious. There's more and more of a role for technology in this. It's possible to code different facial expression by deconstructing facial movements into action units. And action units are just specific areas of the face. So they're groups of muscles that cause facial movement. And each facial movement can be broken up into separate action units and then coded. And this used to be a laborious task that had to be done by watching videos, but it's now automated, and machine learning, artificial intelligence algorithms have been developed. And systems are now available to look at people's facial pain expression. And the one that we're working with is a system called Pain Check that was developed by an Australian team. And this is a mobile phone app that you hold in front of the person's face. It does automatic facial activity coding for pain and also incorporates some elements of the Abbey pain scale. And that's looking at other factors such as whether someone's crying out, whether there are body movements indicative of pain. And then the app will give you an overall rating of whether the person is in pain or not. And this system is also being tested in paediatric populations and in care home residents, and it shows great promise. So leading on from that, we're now conducting some studies in this area. So the main study we're conducting is funded by the UK National Institute for Health Research, and this is the Dementia Comfort and Distress Study in Hospitals, abbreviated to DECODE-H. And this is a study looking at many aspects of agitation, behavioural distress, pain in acute hospital inpatients with dementia, and they've all been admitted for medical illness. So we're doing behavioural rating tools on them, we're doing discomfort rating tools, we are collecting information about the ambient noise, room temperature, lighting, and other stimuli, and we are also collecting data on the presence or absence and severity of delirium, and then finally using the Pain Check tool and seeing how well this works in the acute hospital setting. So it's been a great experience to be the first team to validate this electronic pain tool in the acute hospital. And there's just a picture there of two of our research teams, so our senior research fellow, Emily West, and one of our PhD students, Justin Chan, who are using the Pain Check app in someone who is frail and very unwell and nearing the end of life and has dementia. And we had to stop, obviously, halfway through the study because of COVID, but we really hope to restart soon. We've got data on about 100 patients so far, and we're doing full validation checks, which is why we have two people using the tool at the same time. And then we're also conducting a meta-analysis and systematic review to try and understand better and in more rigorous detail the relationship between pain and delirium in hospitalised older people. And that's both medical and surgical populations, and that's just being written up at the moment. So I hope this has just given you a flavour of what an interesting topic this is. I think I've put my email address on my first slide. Please get in touch if there's anything else you'd like to know. And I hope you have a very enjoyable World Delirium Awareness Day. Thank you.